Welcome to Nursing Grand Rounds. As you see today, we're going to speak about bariatric patients, those who've had surgery and those that are here as a bariatric patient in a non-surgical method. Heidi Daniels here with us. She is the manager of our bariatric program, and we'll get started right away. Heidi?
Thank you, Sharon. And thank you, everybody, for coming today. I see a lot of familiar faces, friends and fellow nurses. So I'm going to start off by introducing myself as Heidi Daniel, for those of you who don't know me, and I've been with this bariatric surgery program for the past 10 years. We started off with 2 bariatric surgeons and did 1 bariatric procedure. And now we have 3 surgeons and do 3 different procedures. And I would like to be known to you as a resource. If you ever have any questions on the bariatric surgery patients, please don't hesitate to contact me. You can get a hold of me through the hospital operator. My office is across the street at the pavilion. And let's get started. Today I'm going to talk about the disease of morbid obesity. I'm also going to talk about sensitivity and empathy training, bariatric mobility and patient-safe handling, bariatric surgery procedures, symptom-driven complications, and pregnancy after weight loss surgery. To start off with, obesity is a lifelong, progressive, life-threatening, genetically related, costly, multifactorial disease of excess fat storage with multiple comorbidities. And comorbidities are just the obesity-related health conditions, the diseases that are a result from the obesity. We start off with the classification of obesity. Underweight is less than 18.5 of BMI. Normal weight is 18.5 to 24.9 BMI. Then we get to the overweight category, which is 25.0 to 29.9. And then we run into the obesity categories. And we have them divided into 3 different classes, class 1, 2, and 3. And class 3 is the morbid obesity. It's greater than 40 BMI. Our patients who come to weight loss surgery are required to have a BMI of greater than or equal to 40 BMI. Most insurance companies will take the class 2 obesity, which is the 35 to 39.9, if they have diseases already documented by their primary care doctor, such as diabetes, hypertension, high blood pressure, osteoarthritis, sleep apnea, PCOS. This list goes on and on. We also look at the classification of obesity in men. Men are at increased risk if they have a waist circumference that's greater than 40 inches, and women are at an increased relative risk if they have a waist circumference that's greater than 35. So we use the BMI plus the waist circumference as the classification of obesity. The prevalence of obesity is that there are more than 33% of adults and almost 17% of youth who are obese in 2009 to 2010. I've put a handout out here for you that shows the different states and the prevalence of obesity in the different states. And it's interesting because a lot of people will sometimes kind of try and guess. You can probably guess what are the more high incidence of obesity states versus the lesser. Anyone want to take a guess on that? Mississippi. The South, Mississippi. Yeah, it's the Georgia, Mississippi, the Alabama. You can see those. And the most normal BMI, anyone want to take a guess at that? Colorado. This is from 2011. I want you to notice the pale tannish yellow states are the BMI of 20 to 25%. And then it goes into kind of that golden color, 25 to 30%, and then the darker red color, orange color, which is 30 to 35. And look at our state, California, for example, and also look up there at Wyoming, which is right up there. Watch that state change, interestingly enough, but watch our state of California. So every year, the incidence of obesity increases in our nation. It was interesting, though, that Wyoming went back a little bit. So there's no state that had a prevalence of obesity less than 20%. There are 9 states and the District of Columbia that had a prevalence between 20 to less than 25%, and then 13 states had a prevalence equal to or greater than 30%. So this is an epidemic. It's not going away. I copied this out of Time magazine. It actually is really long, and so I'll just kind of scroll down. But interesting, it says USA has the second highest obesity rate in the world after Mexico. And there's our percentage of people who are obese. There's $160 billion a year spent on obesity. The individual cost is staggering. Lost wages is pretty amazing as well from obesity-related illness. And there's another one in here that was talking about the amount of gasoline that's used because people are heavier in airlines, trains, cars, things like that, because the passengers are heavier. So we know that obesity is common, it's serious, and it's costly. And I want to start off by saying that because there is such a high incidence of obesity, and we are in an epidemic in our nation and in the world of obesity, we're going to see, as nursing staff and caretakers, more and more patients come through our doors, whether they're coming for weight loss surgery to make some positive changes in their life and become healthier, or if they're a bariatric medical patient that's coming through our doors. It's so important to treat these patients with sympathy and empathy. Training is essential. So I've handed out a sheet of paper here that will have a slide, kind of a wordy slide. So I just handed it out to you, and we'll review that in just a couple of minutes. But I did want to let you know, if anybody ever had like 10 pounds that they want to try and lose, just 10 pounds? Yeah, you know how hard it is to lose 10 pounds? When a patient is 100 pounds or higher over ideal body weight, it's almost physically impossible for them to lose that weight. And they certainly do not have that choice. If somebody came to them and said, you can be skinny or you can be 100 pounds overweight, majority by far would say, I do not want to be overweight. It's a very real problem to them. They've been stigmatized by society. It's important that when they come through the door seeking help, that we don't stigmatize them as well as healthcare professionals. So some of the genetic and environmental factors that influence obesity, there are genetics. Definitely a family history. You can see the family picture down there at the bottom. Family history, if you have 2 parents that are overweight, your chance, because in your genes you have a higher incidence of obesity. We also have metabolic disorders. There's hormones that they have isolated in the stomach. Ghrelin is one of them. Ghrelin is a hormone that proliferates in an obese person's stomach, and it causes them to feel hungry all the time. Once they have weight loss surgery, especially with the gastric bypass and the sleeve, when the stomach is greatly reduced, this ghrelin is also greatly reduced, and they don't feel that hunger as well. There's also other hormones, PYY, TCK, there's leptin, there's melanocortin. So these hormones definitely have an influence on obesity. There's also environmental factors, decreased physical activity, dietary intake. With this past 20 years, where this epidemic of obesity really became noticeable to our nation, you also see that there was a great influx in fast food places and the supersized me and different things like that. And I think a lot of the dietary portion has begun to have attention taken on it, and people have really been starting to try and make some healthy changes. But unfortunately, there's also a culture within a family that are obese that do eat poorly, and it is something that is hard to just snap your finger and just take it away. So understanding obesity, our medical society really understands very little about the true cause of obesity. They've done a lot of research on mice and obesity, and where mice don't have a clue that we know of whether People magazine says that they're the 20 greatest looking mice or not in the world, they start studying these mice too. There's really no drive from a personal quest to be thin and attractive. I mean, we think mice are mice, but there is definitely a genetic and a hormone that they have started isolating, but we really don't understand the true cause of obesity. we need to understand that the disease is not fully understood, and sensitivity to the patient's body image is extremely important. Consideration for the patient as an individual, because most morbidly obese patients have unsuccessfully fought the disease most of their lives. It's very important for us to understand that as healthcare providers. And there's a slide that shows about the circle of obesity, quality of life issues, there's physical discriminations, environmental discriminations, and social discriminations. With our bariatric surgery program here at St. Joseph Hospital, we have a designation that is a bariatric center of excellence. And when our site surveyors come in once every 4 years, they may come around and ask the staff, did you have your sensitivity and empathy education? And over in the red over there is where we complete our sensitivity training. We have it in our ACE manual. All new hires go through orientation. You can get resources online through our CareNet. And then I periodically come around to some of the different units and do in-services. And this is where I want you to take a peek at this. And there's our tips, tools, and strategies. So this is just tips, tools, and strategies, but because of a timeline, I'm not going to go over every detail of it, but I do want you to take that, read it, pass it around to some of the other nursing staff who haven't come to the in-service today. So how do we find a cure? If obesity is a disease, how do we find a cure? So here at St. Joseph, we do provide bariatric surgery. We offer 3 different procedures, and I wanted to give you a little bit of a background how each one of the procedures works. We have the 2 on the left that are restrictive. The Roux-en-Y gastric bypass on the right is malabsorptive as well as restrictive. You can see the stomach on the far right under the gastric bypass has been divided. Then larger portion of the stomach where it goes into the duodenum is completely bypassed, meaning that food will never go into there anymore. So essentially when a patient eats something, it drops down into a golf ball-sized stomach. See where the intestine is brought up and sewn to the bottom of that little golf ball-sized stomach pouch. The food quickly gets absorbed into there. Because it bypasses that duodenum, foods that patients eat, vitamins and minerals that they take are potentially not absorbed very well because it does not go through the duodenum anymore. So therefore, it is a malabsorptive procedure as well as being restrictive because it's a very small 15 to 30 cc stomach pouch that's created. The 2 on the left are restrictive only. You've heard of the gastric band. The gastric band is a silicone band that wraps around the outside of the stomach. It has a long tubing with a port that is placed in the lower part, mid to lower part of the abdomen, under the adipose tissue on top of the muscle. The port can be accessed by the surgeon in his office anywhere from about 6 weeks to 8 weeks after surgery to inject saline into there. The saline will travel up through the tubing and squeeze down around that band that's wrapped around the upper portion of the stomach, hence leaving the patient feeling very full and satisfied with really small amounts of meals because this is where most of the sensation is for fullness and satiety at the top of the stomach. So therefore the patient can lose weight without feeling like they're being starved to death constantly. The food will eventually move through the stomach and go down through the duodenum and absorb. So it's just an implanted device. It can stay in for 20 years or more. The gastric sleeve is the most recent procedure that we have begun doing surgery on patients with. It's the most recently FDA approved. We see some really great outcomes with the gastric sleeve. It's not quite as invasive as the gastric bypass because you're not rerouting the digestive system. What you're doing is you're taking the stomach and creating a long, narrow sleeve. It looks kind of like a long, narrow sleeve instead of that rounded area. They take about 2/3, about 75% of the stomach out permanently. It leaves a very narrow channel for the stomach. The stomach is a stretchable organ, so it will stretch out as the patient eats months after they are healed. But there is very little, if any, malabsorption of their vitamins and minerals in food because the food still travels through the regular digestive tract. So here's the advantages and the disadvantages of the banding system. You can read over those. With the gastric band, it takes the patients more like about 2 years for them to lose the weight. It is very important that they have regular follow-ups, because if they're not going in and seeing the dietitian and the surgeon for fills, things like that, they can stall on their weight loss and become very frustrated as well. It is an implanted device. The band could slip. It could erode, which means it's just eroding into the tissue of the stomach. And a lot of people do like this because it's the least invasive. And if they don't want it, they just get it taken off. Sorry, it's not wanting to turn very quickly. Okay, the vertical split gastrectomy. The advantages to that are that it's a faster weight loss than the band, yet it's less invasive than gastric bypass, no implanted devices. It is involving a cutting and stapling of the stomach, and people do need, with all 3 surgeries, they do need to take a multivitamin. With the gastric sleeve, we do encourage them to take a calcium, a B12, and an iron as well. And here's our gastric bypass. Gastric bypass is considered the gold standard. It's been around the longest of all the weight loss surgery procedures. It started off, they started doing patients, when they would do a Whipple procedure, they changed up the anatomy such as this. They started noting that those patients who got well really kept their weight off, and so it's kind of a takeoff from that. But the gastric bypass has a faster initial weight loss than any of the other 2. And the disadvantages are there's nutritional deficiencies. People could get anastomotic strictures. That's where the bottom portion, where the intestine is brought up there. Some of the bottom part of the stomach can get a lot of scar tissue and become very, very narrowed opening. A patient would have to go to endoscopy after this area has healed, and they could use a little balloon to dilate open that anastomosis. Patients also can get dumping syndrome because if they eat anything that has sugars or high fat or high carbohydrates, goes into the stomach, drops into that intestine, absorbs very rapidly, and will cause what's known as dumping syndrome, where their heart beats, they get cramping, diarrhea, they just want to crawl into a ball, they're profusely sweating, they just feel absolutely miserable. The gastric bypass is extremely difficult to reverse as well. So there is a summary of our 3 procedures. You can see the sleeve and the gastric bypass have the most amount of weight loss per week, and the band is a little slower. This says there is no need for vitamins. We still recommend that they take a multivitamin, because of the amount of food that they're being able to eat at each meal. It's really hard for them to get in all their fruits and vegetables and proteins and everything. So. Weight loss surgery brings a lot of resolution. You can see on here all the different things that are resolved with weight loss surgery. This one is interesting, the polycystic ovarian syndrome, and we'll talk about that in a few minutes about pregnancy after weight loss surgery. So a lot of times women think that they are unable to have babies, that they're infertile, and as soon as they lose the weight, their hormones all start kicking back in, and unbeknownst to them, they're ovulating and they become pregnant. So you can see all those different things. Here's a picture of our 3 surgeons at St. Joseph's. We have Dr. Hamamji, Dr. Jondrud, and Dr. Pham. And Dr. Jondrud is our medical director this year. So let's talk briefly about complication management. I have some posters that look like this, and I'll go over them with you in a couple of minutes, and I encourage, if any of you want any of these for your floors, if you see bariatric patients that come through, it's nice because it's symptom-driven. I've also put the symptom-driven complications on CareNet. So if you go onto CareNet and then you look under nursing resources and go under bariatrics, I have a list of all the symptom-driven complications. And it starts off, if a patient is admitted and they have nausea and vomiting, what could it be? And it has rolled out the different things, also labs that you might anticipate that the doctor would order and things like that, and what to do. And then this is our poster. It comes from the American Society for Metabolic and Bariatric Surgery. That's what ASMBS stands for. It's really nice, too, because it's color-coded. So you've got a nice color code up in the corner. And let me turn the slide. There we go. You've got color code up in the upper right corner, and it has the complications, and then they are color-coded to these different boxes there. And then down the left-hand side, it's got the gastric bypass, it's got a vertical banded gastroplasty, which we don't do here at St. Joe's, duodenal switch, which we also don't do, the gastric sling, which we do, and the band that we do as well. So that's a really nice resource as well for you because it also has some anticipatory guidance as well on there. But they're the clinical pearls for emergency care of the bariatric surgery patient. Again, if you want some, I have them down here, and you can put them in your lounge. Now, most of you have had the bariatric mobility and patient safe handling through our skills day, clinical skills day with Brian a couple weeks ago. So I'll just go over this real briefly. I want to make sure that our nurses stay safe when they are handling and mobilizing bariatric surgery patients. So we do have a numerous amount of resources for you. We have a wonderful lift team that carries all of our bariatric equipment. If they don't carry it, they will find it for you. And there's our contact numbers for them. We also have bariatric wheelchairs. Volunteer department has some of those. And let's talk about the education and support. So as a nurse taking care of a bariatric surgery patient, you can know that the patients come to you well educated. We do put an emphasis on the fact when we educate patients that surgery is only a tool. It definitely is not the easy way out. It's not the magic bullet. And I tell patients that all the time. It's an everyday decision. There's the cognitive side of eating and what food represents to them, as well as the physical side. So it's important to address cognitive behavior therapy as they're going through weight loss surgery as well. Here's Natalie, the dietitian, and myself. We both run support groups. We also have a psychiatrist, Dr. Phillips, that works with our program as well. And this is kind of a quick view of the education that every patient goes through when they come through our program here at St. Joseph Hospital. And I want to encourage you to, when you're taking care of bariatric surgery patients, whether they're coming back 3 months later or 6 months later, to remind the patients to check back in with their support group, attend support groups. Support groups are held over at Sister Elizabeth Building on Tuesday nights, twice a month. And check back in with the surgeon, the dietitian. Once they pay a $200 dietary fee, they have a dietitian for 5 years without any co-pays. It includes all their education and classes, so there's really no reason why they can't check back in with that dietitian. So sometimes it's just sitting back down with her for a half hour or an hour and reevaluating what they're eating, why they're eating, things like that. It's important, too, for the nursing staff to know that patients are educated with protein first with every meal. Every time I ask them, where's the protein in your meal when you start eating? And that's one of the most important things, from legumes, beans, eggs, of course, meat and other products, yogurt, cheese, things like that. Lentils, great sources of protein. I also encourage the patients to remind them, where's your vitamins? Are you taking them every day? Gastric bypass also needs to take the iron and the B12. And water, 64 ounces of water every single day. And we do educate that the patients should not be drinking fluids with their meals because their stomach is so small that if they're drinking water or fluids, for one thing, it fills their stomach up before the protein gets in. They're not able to eat as much protein. And secondly, when they eat the protein first and then pour the water down by swallowing it, dilutes the protein and then it goes out and leaves people feeling hungry faster. So that's a two-part. We teach them the 30-20-30 rule. 30 minutes before their meal, stop drinking water, take about 20 minutes to eat their meal, and then 30 minutes later resume drinking water again. Other important reminders for nursing is that we educate on no NSAIDs, no non-steroidal anti-inflammatory drugs, because those are very harsh on the stomach when it breaks down inside the stomach. When their stomach is greatly reduced in size, the NSAIDs, Advil, Aleve, Motrin, even prescription medications can be very irritating and predispose them to having ulcers inside their stomach. So very, very cautious. We just tell patients just take Tylenol if you have a headache instead. If Tylenol doesn't cut it and you have to take a Advil once in a blue moon, it's not going to hurt you. But certainly if you're taking the NSAIDs every 6 hours or twice a day, you're at a very high risk of developing ulcers, and those are really hard to heal. Also with nursing staff, reminder not to ever blindly insert an NG tube. You need an endoscopy order. Again, right after surgery, very tender areas that are healing. We don't want any perforations going through. And after surgery, meal procedures, patients are instructed not to drink when they're eating meals. We encourage the nursing staff to please encourage patients to sit up for all meals. The patients after surgery are on a clear liquid, sugar-free clear liquid diet for 3 to 5 days. So while they're here, that's all they're going to be eating. And then when they go home, they're back on a protein meal replacement for 2 weeks. They see me, and they also see Natalie at a 1-week visit and a 2-week visit. And then Natalie, the dietitian, at 2 weeks will start them back on solid foods. Since DVT is the #1 cause of death after bariatric surgery, and that's according to the International Bariatric Surgery Registry, very important, and we educate in the pre-op class. The patients, I drill it into them, you've got to get up and move and walk within 6 hours from the time you arrive to the floor, and then every day, up and moving every couple hours, every day after that. And then we also put all of our patients on a once-a-day injection of Lovenox. They have to go home with that. So it's important for the nursing staff to do the education for self-injection of Lovenox because they will go home with that at 7 to 10 days, for 7 to 10 days after surgery. And I do educate and they do watch a video in the pre-op class, but there's nothing like hands-on. So let's talk briefly about weight loss surgery and pregnancy. Our surgeons require our patients to make a commitment that they're going to wait at least a year to 18 months after weight loss surgery before planning to get pregnant, or longer if they're still in the active weight loss phase. Gastric band patients would be longer because it takes them about 2 years to lose their weight. And this slide got a little bit smushed, but there's your deficiencies. There's the lab testing, and if anybody wants this, please contact me and I can get this slide to them. It just talks about the different supplements and the lab testing. You can see over on the far right under protein, most of our patients need 60 grams additional protein a day, along with their regular balanced diet to support the baby and the baby's needs. This is one of our patients. Her name is Luz. She also works for Dr. Pham. That's her before picture, and that's her afterwards. Because of weight loss surgery, she had a mammogram, and because of the density of her breasts and the weight loss, they were able to find a mass. She feels like weight loss surgery saved her life because she said she probably, A, wouldn't have gone to get her mammogram, and B, she just didn't do self-exams, but she did find that lump and had her mammogram. She's doing good. She's a wonderful advocate for our patients and so healthy. She's gotten rid of her diabetes, high cholesterol, a lot of other things that she was suffering from. So thank you for your attention. Can I take some questions? Anybody have any specific questions, or is there anything I can get for you for your floor? Yeah, should be.
I just have a question. Sometimes when the active lifestyle patients come, often my doctors will send them to have a surgery there. They come back. The question is for vitamins and minerals and all that. Do they have to bring their special vitamins? Can you give them what we give into our patients?
That's a good question. Vitamins and minerals after having an orthopedic procedure. You're right. A lot of orthopedic doctors will send their patients to us so that they can lose 50, 100 pounds. So they're a safer weight loss, safer orthopedic patient during surgery and for their rehab. And once they've lost their weight and they come to you, they are on their own vitamin regimen. By the time they come to you, I'm hoping that they've lost 80 to 100 pounds, and they can swallow some pills, but a lot of them like to continue with the chewable vitamins through Bariatric Advantage. So if, for us, it would be fine if they wanted to bring their extra vitamins and minerals to you, but usually what we would say is, during their hospital stay, they could take the hospitals, but once they get home, they go back on their regimen. A lot of them have to take extra iron and things like that, and calcium as well. Other questions?
Thank you all for coming.
Yeah, thank you. Have a great day.